Hi, everyone, and thanks for joining us. I think we're just waiting for one more panelist to join us, so I will just briefly welcome everybody. Thank you for joining us to this COVID-19 Q&A session. My name is Whitney Golston. I'm the Executive Director for Canadian Immunodeficiencies Patient Organization, CIPO. And we've had a couple of these already, but thank you for joining us here today. Before we begin, I just want to do a brief land acknowledgement. CIPO's offices are in Victoria, BC, which is where I'm joining you, and we acknowledge the traditional unceded territories of the Lekwungen-speaking peoples. I'd like you all to take a second and just briefly acknowledge where you are joining us from today. Today we have with us two of our wonderful medical directors. Although I don't know if, Kyla, are you with us yet? Okay, well, I know Bruce is here. Today we will have both Kyla Hildebrand and Dr. Bruce Ritchie. Dr. Bruce Ritchie is a professor of medicine and hematology at University of Alberta in Edmonton, where he is active in both clinical and basic research. As the director of the Canadian Biosample Repository and the medical director of the Dr. John Akabudu Comprehensive Center for Rare Blood and Bleeding Disorders. And Dr. Kyla Hildebrand, who will be joining us, is a pediatric clinical immunologist and clinical educator at BC Children's Hospital. She's also the clinical associate professor in the Department of Pediatrics and Division of Allergy and Immunology at UBC. Today is a Q&A session. So I would just like to state that we have had a lot of questions come in over email. We've had over 50 questions today. We're going to try and get to all of those questions in this session. And as well, during the session, you can use the chat function or you can use the Q&A function. We will address also the pre-submitted questions. If we cannot get, this is a 1-hour session. If we cannot get to all of those questions, we will attempt to have our medical directors answer those questions. So I'm going to, if you do have any technical difficulties, please email CIPO office, that's David, who's with us today, directly in the chat, and we will help you as best we can. So Bruce, if you don't mind, I'm going to start with you while we wait for Kyla to join us. The session is being recorded and we will be sharing this session with everybody as well afterwards. Okay, so Bruce, I'm going to kind of put it off to you. And at first, we're having a lot of questions in regards to the mandates being dropped across the country and putting everybody at risk. So how can people protect themselves, especially in the immune deficiency community, now that mandates are being lifted across the country?
Yeah, that's a great question, and it's a hard question. I've been thinking about that a lot with myself and my own family, so it's timely for me as well. What we know is that the COVID-19 virus has evolved quite a bit over the last 2 years since we've been in the middle of this pandemic. Actually, it's 2.5 years. I remember in 2019, when I saw this on the news, I was overseas. I was actually over in New Zealand visiting my mother-in-law, who was turning 99. And I said, this is going to be a big thing. And I started telling everyone not to touch handrails and elevator buttons and stuff like that. And people laughed at me for the first 3, 4, 5, 6 months. They said, hey, you pegged it. But anyway, the evolution of the COVID-19 virus has been really an important thing. What's happened is the virus has evolved to become less severe and more infectious. And that's what typically happens with things like parasites. If they kill the host, the parasite doesn't last very long. So a good parasite, like a virus is, really wants to sort of live within the host without causing too much trouble. And I think what we're seeing is sort of an evolution in that direction. When we first started dealing with COVID-19, we talked about an R0, or what the Brits call an R0 value, which is how infectious it is, and which means the number really says if one person has it, the number tells you how many people that person might pass it on to. So the original virus was like 1.7. And the masks and everything worked reasonably well against that sort of thing. We had a lot of bad advice early on. In fact, in my institution, we were told not to wear masks in the hospital. And I protested against this, and but that was their rules. So, lots of things we got wrong. When the Delta virus came along, Delta variant came along, it had a higher R0 value of 2.7, which meant it was, almost twice as infectious as the original virus, and it was quite severe. But the masks and everything were still working reasonably well. When we got to the Omicron variant, which is now, I don't know, 3 or 4 months, we're 3 or 4 months past that, it had an R0 value of 20. And what that means, the R0 value of the Omicron was about 12, but it means that every person who had it could pass it on to 12 other people. So it was much, much, much more infectious than the original variants. And we saw that too. It went through the population despite all the mask wearing and hand washing and everything was doing. We saw it spread very rapidly. In fact, the R0 value is similar to what it is for measles, which is considered one of the most infectious agents there is. So, and so that background tells you a little bit. It just informs us about how effective some of these things are going to be. So the masking with the regular blue masks like this aren't going to work so well. And the N95 style, or here's another one, masks are going to work better. But still, masking has a couple of benefits, because when you're masked, people don't know if you're masking because you've got COVID or because you're trying to keep from getting it. So the good thing about wearing a mask is people tend to stay away from you. And that's, I think, a good benefit. So people who are at high risk really should, I believe, continue to mask and try and avoid crowds and things like that, because it's in the air, and all the good data now that's come out shows that transmission really is dependent on airflow in buildings and outside and things like that. And really, in the future, we should be building buildings with better airflow. And there are things like UV lights that could be put in the airflow returns that will actually kill the virus and stuff like that. But for now, the best thing you can do is get vaccinated, because it may work in you, and it's better than getting the virus. And wear masks, do hand washing, do everything else. So that's a long answer to a short question. You're muted.
I just saw that. As a follow-up, what kind of masks would you recommend people use? Do you recommend the N95? Do you recommend or higher?
Yep, I would use an N95. In fact, that's what I do use. So when I'm working where I am now in the K clinic, I wear one of these blue masks. And only when I'm out of my room. So you can see I'm in my clinic room in the background there. But when I'm out of the room, I use a blue mask. But if I'm going into places where people have not been pre-screened, like everyone in our building is pre-screened and answers forms and stuff, so we think that helps the risks a little bit. But if I'm going to a grocery store or something like that, I wear an N95 mask.
And what about, we've had a question here of, should people with, like, I don't know unknown COVID status. So they're not pre-screened. I don't know, but they're coming into my house or they're coming into an area where I am. Should we ask them to wear a mask if they're coming into our house and we don't know what their COVID status is?
Yeah, I think so. You know, this is a very difficult social area right now. But what I do is I tell people I don't want them to come into my house unless they've been vaccinated. And if they're people I don't know that are outside my bubble, I want them to wear a mask. And if they say they don't have a mask, I'll give them one of our N95 masks to wear and say, happy birthday.
That's great. So, I mean, do you think the surgical masks would be enough, or would you recommend a higher up for people with PI?
Yeah, I recommend the N95 if you're really, with the Omicron and the BA2 variants, they're so infectious that if you're really trying to protect yourself, you need an N95. I think the blue masks, the surgical masks, really, they do a better job of protecting other people against you than protecting you against other people. So to protect yourself, really, you need the N95 mask. Excuse me.
So kind of to carry on with this vein, now that the mandates are open, we've had a lot of our community has stayed relatively isolated over the last 2 years. So do you think that people should continue to avoid going into stores or outdoor or even indoor community events? And what about visiting family members or even family members that may be unvaccinated? Under what circumstances? Because obviously we wouldn't know the vaccination status of people in the community. Oh, Dr. Hildebrand has joined us now. So I'm going to welcome Dr. Hildebrand.
Hello, apologies for my technical glitches. Nice to see you.
I'm going to actually throw this question to you then, because Dr. Ritchie has been so kind to answer all my questions for the last little minute. Yeah. Thank you for being able to join us. So we've just been talking about masking and the lifting of mandates. So I'm going to say, a lot of our community has been isolated for a long time, but we've had some questions about should people avoid going into stores or community events? Would it be safe to visit family, and under what circumstances would that be?
Yeah, that's a great question. I mean, I think every family and especially individuals who have chronic conditions where they are at an immune compromised sort of position, I think those decisions are not taken lightly. And certainly when the mask mandates ended some weeks ago, it caused a lot of distress amongst my patient population in terms of, they felt rather safe up until then, relatively speaking. So, my advice in my own practice has been to, advise families to do what feels best for them. I think as I heard sort of the tail end of Dr. Ritchie's answer about the N95 masks, I think that's really great advice. We know that they have a better seal and they do work they're a better layer of protection for our patient population, especially. In terms of gathering with others or going into grocery stores, I mean, life is life as well and does need to move forward, and we all have sort of daily tasks to complete. Sometimes those things can be delegated, but if not, I do think like good hand washing is really imperative and makes a big difference. Wearing our masks indoors, I think, is really helpful. And for family members, who may or may not be immunized, I think that's sort of a decision everyone takes individually, but certainly outdoor spaces are sort of one sort of venue that probably is optimal in terms of having good ventilation. I think we have lots of recent studies as well that show that ventilation is really important in mitigating transmission of COVID-19 and other viruses specifically. So that's sort of the advice I've given my patients, and every individual will make a decision that fits best for them, because seeing family is also really important, and it's been a long 2.5 years.
Yeah, I might jump in there. I agree completely with everything that Kyla said. The whole ventilation thing is a big thing, because when you're indoors, you have no idea what the ventilation's like. And with COVID-19, the dose of virus you get seems to have an impact on how severe the disease you might have is. So, minimizing the dose by having good airflow is really critical. And when you're inside a house, that's hard to predict. For me, I'm supposedly, apart from being old, I have a normal immune system, but I still stay away from crowds and things. Like, I haven't been to a theater for years, and I won't go again for a long time, just because I don't want to get COVID-19. I don't want to pass it on to friends and family. I just don't want to take that risk. So I go to the grocery store, but I always wear a mask inside, even though lots of other people aren't. And I commonly wear an N95. And if people think I have COVID, which is why I'm wearing the N95, all the better if they stay away from me. Back in the day, pre-COVID, people wearing masks, we used to think they all had TB. So we'd stay away from them, which is a good thing. But so airflow is critical. Most buildings that weren't, made in the last 10 years haven't been designed to have good airflows. And so that's a real problem.
So what can we do to take extra measures other than mask wearing and wear a good mask like an N95 for things like sending our children to school?
Yes, so the school question comes up quite a bit. I would also add that we have really good studies that have shown that the impact of this pandemic on children has been far greater than we imagined as it relates to social emotional development. And that's a really big piece that we need to remember, that kids need other kids to socialize and learn and grow and experiment. So I think school, again, it's an individual decision, but I do think that school is a good option for most families. A lot of children, healthy or not, continue to elect to wear masks in the classroom. And, depending on the community in which you live and the relationships you have with your schools, I think sometimes having a conversation with other families or with the teacher, you might be surprised at how protective little kids are of each other and their friendships, and they really rise up. So I think that if other friends knew that if they wore a mask, it really was protecting a friend that was vulnerable. Kids understand that. Even I have, my youngest are in grade 1, and they understand that. So I think it's worth sort of having conversations if you feel comfortable opening up to your community, to other parents in the classroom, that may be a starting point to consider as well.
Thanks. That's great. So we're going to move on to testing, if that's okay. There were a lot of questions submitted about rapid tests and how effective they are, how we can use them to our advantage. So I'm going to just start off with, how effective are these rapid tests?
Well, I can take that one. We actually just did a study at our assessment center here with a company that had a new rapid test, and it was very good, very sensitive, but it was not 100%. And so, and we knew that because we were comparing it to the PCR results, which are more sensitive. It's a more sensitive test. So there were definitely people who were positive by PCR, but negative by this more stringent antigen test. So the antigen tests aren't perfect. And they are, and any test is only done at a small window of time. One of the good things that's happened in my family recently is everyone got COVID, my children and grandchildren. They got COVID and got through it, and they're all quite happy now that they've been through it, which is sort of nice. They were all vaccinated, so they probably had less severe cases. But it was interesting to see the testing that was done in the family, how people tested positive at different times in the course. And some people who were sick didn't test positive for a while, and other people tested positive, and then it was a few days before they got quite sick as well. So the testing is not perfect. It's useful if it's positive. If it's negative, it's a little bit harder to interpret. I think that's the best we can say.
And how should we be testing? His other question is, should we be testing people who come into our house using these rapid tests?
Yeah, that's a great question. My oldest son, I have 3 sons. My oldest son arrived back from Pennsylvania last night around midnight because all the flights through Toronto were delayed. You know, the first thing he did was do a test when he walked in the door. He's been testing frequently and has always been negative, but in many ways, it's a way of building confidence. You know, he didn't want to bring COVID-19 into our house. My wife and I, we've never had symptomatic COVID. We've always tested negative, but you know, it's certainly possible to have asymptomatic disease. So you just don't know. And I think like hand washing, you know, I don't think you can do too much testing.
There's a question about PCR testing. We've had a lot of members write in who've had COVID, but have not been able to access PCR testing across the country. So I think there's a question here about how can we get better access to PCR testing?
Yeah, I think all the immunodeficiency patients should be able to get PCR testing. And the reason I say that is if first you have to have a positive antigen test. In Alberta, if you have a positive antigen test and you're a high-risk population like our immunodeficiency patients, then you are a candidate for monoclonal antibody or antiviral treatment. But they won't actually give that to you until you've had the PCR test. So, but if you're an immunodeficient patient or another high-risk population, and you've had a positive test, you can get the PCR test right away. If you're symptomatic, it's often possible to get it even if you haven't had a positive antigen test. So I think the key thing, you know, in Alberta, you dial 811. You know, calling your doctor is useless. When people call me, I tell them to call 811 because I have no control over this. And they call 811, and if they tell the person on the other end, usually a nurse, that they're immunodeficient and they think they should be considered for antiretroviral or antiviral treatment or monoclonal antibody therapy, usually they just send them along.
Kyla, have you had the same experience in BC?
You know, I think I haven't heard this challenge about getting PCR testing when needed. You know, most of the time our patients, if they are screening positive, they're self-isolating, and then we're working with, you know, individuals to determine if they should have other therapies to help mitigate the COVID-19 infection. So yeah, I haven't heard any challenges in British Columbia about getting PCR testing done, I must say.
And we do have a question too about monoclonal antibody therapy. So there's been, some people have been told that monoclonal antibody therapy is no longer available because the new COVID strain is resistant. Can either of you comment on that?
Kyla, do you want to join?
Yeah, I must admit, I haven't heard that the new COVID strain is resistant to the current monoclonal antibody. As far as I'm aware, it's still being given, you know, rather widely throughout the country. And I think more commonly the antiviral is being administered instead, because it's much easier to access and doesn't require admission to hospital for administration, that sort of thing. So the planning logistics and the resources that go into using the monoclonal antibodies, I think, are much greater. And most likely those are the patients who are sort of peri-transplant or undergoing like intensive immune suppression with chemotherapy, et cetera. But I think for the majority of patients, the antivirals are sort of the go-to treatment of choice. Yeah.
And that is the Paxlovid, correct?
The Paxlovid, yes, correct.
And is that still, just to clarify, is that still you need to take it within the short period of time after your symptoms are onset?
Yes, yes. Usually it's within a few days. I think within 5 days of starting symptoms is when it's most effective in terms of reducing the viral load, which is what the aim of that medication is. And in doing so, that you will hopefully have less severe symptoms or illness as a result.
And have either of you had any experience in patients taking Paxlovid and whether or not that's true?
I can speak. Certainly, I've had patients who have taken it and they have had, rather mild illness. It's always challenging to know kind of what would it have been had there not been an antiviral on board. However, the most common side effect is just a very sort of metallic taste in the mouth. I think every patient has told me that that's been their experience. So it is sort of one of the side effects that's predictable and known.
So
we do have a comment from someone in the chat saying recent evidence suggests sotrovimab may, or Bruce, you can read it out if you want.
well, yeah, the sotrovimab may not work so well against the BA2 variant, and that's true. There is evidence of that. And so certainly in Alberta, we're shifting away from that because almost everyone who's got COVID-19 right now has the BA2 variant. And, a few months back, everyone had the Omicron variant. So these variants are replacing one after the other. And it shouldn't be a surprise when some antibodies or antivirals work better for some strains and not for others. One of the things we said when this whole pandemic started was that coronaviruses mutate very slowly. And that appears not to be the case at all. It's certainly mutating as quickly or more quickly than the flu. So yeah, I think everything is changing fairly quickly. Our public health people are making decisions on the fly as to which antibody or which antiviral to give to people based on the best science. So yes, that's true. But even antibodies that have a reduced binding to the latest variant may still be useful in some patients at reducing the viral load and reducing the infection rate and things like that. There's a very good review on the European Society of Immunodeficiency website. If you Google ESID, ESID, and COVID-19, they've got some very good data and references on what's known about the different treatments and things like that. So that's not a bad place to look for some of that stuff. And there's another question about how do you know which variant you have? You know what variant you have because people are screening the population for it. So again, I can tell you what's happening in Alberta. In Alberta, they take a percentage of all the positive PCR tests and they do DNA sequencing and find out what variant it is. And what we find, as I mentioned, is that each variant comes in and takes over completely and then is replaced by the next variant. So if you have COVID-19 today, you've almost undoubtedly got the BA2 variant. You can never say never say always, but the chances are. The other place we know about this from is that sewage is being tested for these viruses, and it turns out that people are shedding it into the sewage, and the variants are being tested there too. So what I can tell you is the public health people are scrambling like crazy to try and stay on top of this and know what variant is circulating and making suggestions about antiviral treatment and monoclonal antibody based on the best knowledge of the time.
Thank you. So I'm going to move on to because we're talking about monoclonal antibodies and Paxlovid. Evusheld has been in the news a lot, as you both know, and we've had a lot of questions about Evusheld and what that means to the immune compromised and immune deficient population in Canada. So there's been a lot of questions about how that rollout will look like for the immune deficiency population. Do either of you have any input as to what that looks like?
Yes. So maybe I'll start by describing that Evusheld is a combination medication of two monoclonal antibodies that are given via injection. And the main purpose and the authorization for this medication is for prevention of COVID-19 infection. So it's not to treat COVID-19. And it's also not in place or in lieu of immunization for COVID-19 with vaccines that are readily available in Canada. And its main purpose is to offer this medication to those who are immune compromised and who are not thought to mount appropriate or adequate immune responses to vaccines. So many of you will know we've been promoting immunizations for our patient population who are immune compromised, and likely there is some benefit, and depending on the immune deficiency at hand, there may be more or less immune response to it. However, this monoclonal antibody can be given to prevent COVID-19 infection to those who are over 12 years of age and meet a certain weight requirement. And the studies have shown that generally the effect of this antibody is that it remains to offer protection for a period of about 6 to 9 months, which is rather reassuring. And it's also effective against the B2 variant. In terms of the rollout in Canada, I know that Health Canada has looked at this, has approved it. NACI is currently reviewing this information as well to make recommendations. And in terms of how it's delivered at the level of the provinces and territories, will really, I think, I don't have any specific information around that, but I would imagine it's somewhat similar to whatever processes were used to identify patients who were perhaps clinically extremely vulnerable, which is how we in British Columbia identified patients who were at risk, who were immune compromised. And these things are all sort of captured within our provincial kind of databases. And that may be a way that it is rolled out, but I don't know specifically, but that would be my guess.
So that is what we're looking at right now, is the provinces are kind of establishing those processes, but they haven't been established yet.
Yeah.
And that's the same in Alberta. We're still waiting. So the thing about antibodies, these monoclonal antibodies, is from a pharmacologic point of view, they are very similar to the antibodies people are getting for subcutaneous IG or IVIG replacement, in that they have a half-life of about a week. So giving them every 3 or 4 half-lives is not a bad way to give it. So once you've had an injection, it's good for a fairly long time. That's the first thing to remember. The combination seems to be very effective. And I guess one of the questions would be, what would you do if you had the Evusheld and then you get COVID anyway? Would you get yet another monoclonal antibody? And nobody really knows how best to manage those questions, but probably we would use an antiviral drug at that point. But I agree with Kyla. We still don't know, and I think there will be an announcement that'll come out by email, and suddenly we'll start scrambling to try and get our patients treated.
I think there's a question in the chat of if any of us are successful to get Evusheld, how much freedom does that buy us? So will Evusheld be kind of something that allows people who have been isolated at home the ability to go out in the population again and get back out in the real world?
And I think we don't know that yet, but what I think we can say is our knowledge from the vaccines and from previous infection is that protects you a little bit. It's not perfect. And, I think there was a report of somebody who got COVID twice within about 20 days, which is really, phenomenally fast. And they had sequenced the COVID to show it was a different virus in each case. So we know that if you've been vaccinated or if you've had COVID previously, if you subsequently get COVID, you shed it less, so you're less infectious. And that's a useful thing. So it's always useful to get vaccine vaccinated and to get as many people in your bubble vaccinated as possible. But, you know, all of these things are imperfect, and there's nothing that's going to be a magic bullet for this pandemic.
So Evusheld would just be another layer of protection on top of the masks, on top of the vaccines.
Yep, and it may not prevent you from getting COVID, but it might prevent you from getting severe COVID or even passing it on to others. So, you know, I think the vaccination is the first thing to do because it's good to produce your own antibodies, but because we know you can't count on that. And that's one of the things that is in the ECID documentation is they say quite clearly that people with immunodeficiency, many of them will respond to vaccination and they will get an antibody and a T-cell response, but not everyone will. And there's no way in advance to know, you know, who will or will not get a response. And those who do get a response, they tend to have a less vigorous response, both at the antibody level and the T-cell T-cell level to the vaccines. So, you know, they respond less well than a so-called normal healthy person would.
I'm going to ask one question about vaccines since we're kind of on this topic before we move on to plasma products. We've been taking the vaccines, you know, each province is a little bit different, but every 6 months or so, immune compromised patients, immune deficiency patients have been getting a vaccine, and we're on our 4th dose. How frequently is it expected, and for how long at the moment is it expected that immune deficiency patients will be expected to take these vaccines? Ongoing?
Yeah, I can take that one. So I think that it's still to be determined in a way as we monitor the variants that are emerging. And I think that will likely be what enables a pivot towards continued immunization so that our vaccines are keeping up with what is the actual causative agent for these infections. Yeah, I saw a message in the chat as well about the timing of getting a 4th dose. If you've had a past infection with COVID-19 and treated with Paxlovid, generally the recommendation is to wait 8 weeks after you have had an infection with COVID-19. And that the infection with COVID-19 is in and of itself a prime or a little bit of a boost of the immune system, I should say, when you think about like the vaccine series that are given. And that's why there is a recommendation to wait a little bit longer so that you maximize the vaccine response 8 weeks later.
Wonderful. Thank you so much, Kyla. So we're going to ask, there are some questions that have come in about plasma. We know from information that has been sent to us and shared with everyone about antibodies, COVID antibodies showing up in our plasma protein products at this point in time. But there have been questions about how effective these antibodies are against current variants for the plasma protein products that we're receiving now, because we know that it takes about 16 to 20 months for these products to be made. So how effective are the COVID antibodies that we're receiving in our plasma products against current COVID variants?
I was trying to get that information today. I left it a little bit late, but I emailed the companies to say what data that they have on COVID antigen titers, because they do look at this for different pathogens all the time. They're always looking to see how broad their coverage is. I think it's important to realize or to remember that when you're given antibody replacement, it's coming from tens of thousands, if not hundreds of thousands of different donors. And it means, potentially you could be exposed to everything that they carry, although the viral inactivation in it is really fabulous now. So I think the risks from so many donors is not significant at all. In fact, we say people receiving pooled plasma products are at much less risk than people who receive single donor products like plasma or red cells and things like that. but the benefit of being exposed to so many donors is that they will have a variety of different immune responses to different antigens and to different variants. But it is about 18 months behind, from the time a donor donates till the time it's infused into somebody is 18 months. So the antibodies we're starting to see now are going to be to the original COVID-19 variants. And that may be okay, because we know the current vaccines, which were based on the original variants, seem to work as well as even new variant vaccines. So one of the companies, I can't remember which one, made a Omicron variant vaccine, and it didn't seem to work any better than the original one. So similarly, if you look back, it may be that the antibodies we're starting to see in the immunoglobulin products work just as well as newer ones. So, it's one of those areas where it's really hard to know, and there's not a lot of data because the antibodies, it's not just the amount of antibody, but also what it's directed against. Is it directed against the original one or variants and things like that? So,
and I have a follow-up question here too. How will these antibodies help patients who are taking these plasma products who are unvaccinated? Will they still be able to mount a response or somewhat of a response to COVID?
Kyla, do you want to take that?
Yeah, for sure. So in someone who's unimmunized and receiving plasma product, is that the question?
Yeah.
Will they still be able to mount a response? I think it really depends on their underlying sort of diagnosis and sort of which part of the immune system is affected that is limiting their ability, perhaps, to mount a typical host response as we would expect to any virus. So that's probably more important, and likely what's in the plasma itself shouldn't have any impact. It doesn't create any sort of memory, because these are antibodies that are already made. They sort of pass through the recipients sort of through their system, and it gets excreted once it's broken down. So I don't think it should have any impact on ability to mount a response if that ability is already there, to whatever degree that is present.
Yeah, I agree completely with that.
So another question is, what if we've had COVID? What kind of, some people, what kind of immune response can we expect? Have we developed COVID antibodies already? Will we be at risk of getting COVID again? I know, Bruce, you mentioned that somebody had COVID twice in 2 days because of varying strains, but I would just like to kind of repeat that question for somebody who asked it.
Well, I don't mind having a stab at that. There's a couple of things we know about immunodeficiencies, especially with common variable immunodeficiency. It's called that because it's common and it's extremely variable. I don't know what the current number is, but there's at least 70 or 80 genes that have been shown to be involved in antibody production and in which mutations can lead to antibody deficiencies. And it's likely people with common variable immunodeficiency have collections of those genes causing their problems. So everyone's going to be a little bit different, and it is hard to predict who is going to respond and who's not. The other issue is that people with immunodeficiency, and this was particularly shown in patients with HIV and AIDS, they may carry the virus for significantly longer. And, so if you don't make an immune response to it, you might end up carrying it. And if you carry it for a long time, that's thought to lead to many of the mutations that we're seeing. So I think it was the Delta variant that came out of Africa, or maybe it was the Omicron variant. I can't remember what one of them was thought to have come from a particular patient with HIV who carried the virus for a very, very long time, allowing it to mutate within them. So those are all important issues. I think the best anyone can do is get as much protection as you can, get whatever vaccines you're allowed to. So, as a healthcare provider, I've been allowed 3 vaccines now. And as soon as I was qualified for the third vaccine, I got it. And if they'll let me have a fourth vaccine, I'll get it. If they'll let me have any other vaccines, I'll get them. And that's not just to protect myself, but to protect my patients and my friends and family. When patients come to our clinic, and mostly they're still phone visits, I wear a mask all the time. And, you know, I think you just have to do your best and make as much use of as much protective gear as you can. Get vaccinated whenever you can. And if you get COVID, connect with the health authority and see what treatments you can get.
So thank you. I think that's great. I'm going to move on. That takes us nicely into the next thing, which is actually primary immune deficiency patient treatment and recovery for COVID-19. I know that at least as an organization, we've had a lot of patients reach out since March who have contracted COVID in this last wave. So we've had a question here from someone who has had a lot of fear and anxiety about catching COVID-19 over the last 2 years. And they are asking if either of you have any statistics or information about the number of patients with primary immune deficiency who in Canada have received COVID, have gotten COVID, or died from COVID-19.
I can start. I'm not aware of any specific information as it relates to contraction of COVID-19 amongst immune compromised individuals, especially those who have, immune compromise is a broad sort of spectrum. You know, in my patient population, typically we're thinking inborn errors of immunity. What we do know is that not all immune deficiencies are kind of at the same on the same par as it relates to their likelihood of severity of disease. You know, kind of last year there was a very important landmark article that came out describing, you know, why is it that certain patients are getting overwhelming infections with COVID-19 and very severe disease, and others have very mild disease. And we know that if there are genetic changes in the interferon gamma pathways, that this can predispose to very severe COVID-19. Those are relatively very, very rare. I mean, in immunology, everything seems to be rare, but that particular subgroup is even more so. And common variable immune deficiency is much more common in our clinical world. But I think there's also some positive, studies as well that have shown that, you know, those who have sort of phagocytic disorder. So if you have chronic granulomatous disease, there doesn't seem to be a more severe form of COVID-19, generally speaking. Those who have autoinflammatory diseases or even hereditary angioedema, that they tend to not get the very severe infections. And even those who have, profound T cell deficiencies, where we know T cells are part of a combined immune deficiency if they're missing, and they have a very important role to play in fending off and battling against viruses. Even those individuals tend to have, sort of more typical infections. So I think we're learning more and more, particularly as, we're studying our immune deficient population, particularly those who have inborn errors of immunity. I think there's been a lot of great work at a global level and networks that have formed who have been working so collaboratively to help provide more information and to shed light on our particular group of patients that we care for.
Wonderful. Thank you, Kyla. Bruce, do you have anything to add?
No, not really. I might just jump in though and say there was a question, what can we do if we need to go to another province and we get COVID? I think it's like going to another province and getting in a car accident. You get the treatment you need in that province, and then that province bills your province of origin at the end of it all. So don't worry, if you get COVID somewhere, just like they say, any port in a storm, just go and get whatever treatment you can.
That's a good point. As long as you have healthcare within your own province, you'll be okay.
Yeah.
So Bruce, as long as you know, there's no research or studies showing PI patients numbers in Canada or deaths in Canada for PI patients.
Well, we're studying that now, and we're studying vaccine responses and things like that. But there's not strong data. Yeah.
We have another, oh, sorry, go ahead.
Yeah, I mean, what's really remarkable is we have more data on COVID-19 than we have had on any other disease in the history of the world. People who say there's not a lot of data about the COVID vaccines, there's data on hundreds of millions of people who've been vaccinated. Some of the data is in more detail on a smaller number of patients, but we have a huge amount of data. But there's still so much that we just don't know, and the virus keeps surprising us. I think early on people talked about having sort of viral seasons like we did with the flu, and I think that's probably going to happen. I think we're going to have COVID-19 for a very long time. And as Dr. Tam said the other day, it looks like many people are getting long COVID as well. Maybe as much as 50% of people who've had COVID are getting long COVID type symptoms, and there's a huge variety of different symptoms. So, this virus is going to have a huge impact on the population of the planet, and that'll stay with us for decades to come.
I'm glad you mentioned long COVID. We've had a few questions about long COVID, wondering if long COVID has impacted the PI community any differently than the general population, or if there's any knowledge of that.
I can go first. I would say it's something I screen for in all of my patient visits, along with asking around their immunization status and verifying it on our provincial registries. But I would say most of the patients and again, I see pediatric patients predominantly in my practice, but I would say most of them have had kind of a usual course of infection. None of our patients, speaking for my two other colleagues here at BC Children's, none have needed hospitalization because of their infection. And I've not heard of long COVID symptoms in any of them, which I think is reassuring.
That is good.
Yeah.
And I guess maybe we'll find out more as we go on.
Yes.
Yeah. Unfortunately, you learn as you go through it. But I think there's a couple of interesting things, like you're not more likely to get long COVID if you've had severe COVID. And there are people who had very, relatively light cases of COVID who end up with long COVID that can last a long time. So it's a bit unpredictable. There's just a lot we don't know. People who get blood clots, for instance, we've been treating them, or at least my colleagues have been treating them as provoked clots, which means you get 3 or 6 months of treatment and then stop treatment. But there's a lot of evidence now in long COVID patients that they continue to have predisposition to blood clots that goes on for 6, 8, 12 months, as long as they're having symptoms. So, I think we're sort of winging it quite a bit, trying to make best decisions based on best evidence all the time.
Kyla, I'm going to ask you a question too. We've had some questions about children and children with PI, and how are they faring during COVID?
Yes. So kind of, I guess, in follow up to my previous answer, our patients have done relatively well. We follow, most of our patients are under the age of 12 for the most part. Many of them have not received immunizations because they just aren't over 5 years of age. And, we're hopeful that we'll have some vaccines available for the 6-month to 5-year-old age group, perhaps this fall in Canada. We'll see. But I think that, again, they're not even being hospitalized or even presenting to the emergency department, which I think is very positive and reassuring.
That's great to hear. And Bruce, because we're wrapping up in a minute, but I'm going to ask a few more questions. While I can, we did have a question about the plasma supply. Should we be worried about how COVID-19 is affecting the plasma supply in Canada?
I think so. Insiders in industry have told me for the last 18 months or more that it was going to be a problem, and that because of COVID, lots of less people were donating. And so we should really be running into that problem right about now, because the pandemic is 2.5 years old. it's thought that it will affect IVIG more than sub-Q IG. But so far, we haven't been asked to restrict IVIG use even. So all I can say is wait and watch. You know, I think medicine is changing so fast and so dramatically. There's a lot of IVIG used to suppress the immune system. About half of the IVIG or antibodies that are used in Canada are used for replacement, and half are for immune suppression. The doses are a lot different and the numbers of patients are a lot different, but there's a lot of interesting work being done with alternative treatments for those patients that need immunosuppression, and things like recombinant FC fragments and monoclonal antibodies against FC receptors. And these are all very exciting. Nobody knows how and when they'll pan out. But if they do start to work out, it will mean about half of the patients who are getting immunoglobulin treatments right now may switch to a recombinant product or something else that may free up a lot more plasma for the rest of our patients who need it for replacement. So I think there's a possibility. I've been speaking about this for the last 2 years. Whitney, you've heard me mention this many, many times over the last 2 years about the impending shortage of immunoglobulin, but so far we don't seem to have hit that wall yet. So stay tuned.
Okay.
And I will, if I can just add, I certainly,
Of course.
as you, Dr. Ritchie, have likely been at tables of discussion, especially very early on in the pandemic when that signal was first and that concern was first raised. You know, I was so impressed by Canadian Blood Services and knowing that Héma-Québec was also kind of in alignment with the same sort of strategies in mind, but the mitigating sort of procedures that that were being developed to ensure that product was being used appropriately and judiciously. I felt very confident that our patient population would be well served. Again, although IVIG and immunoglobulin replacement was generally started because of antibody deficiencies, we use the least amount of product compared to all other conditions, but our use in Canada has increased year over year and is on like an upwards trajectory. We're one of the top users in the world. I would say, I think we're one of the top 2 or 3 users in the entire world. So more, yeah, like Dr. Ritchie says, stay tuned, but I am confident our patients would be well protected.
Yeah, I think we're very lucky being in Canada because, we're one of the richest countries in the world, and certainly in Alberta, we are oil rich, and most of us as Canadians have come to expect a very high standard of healthcare and standard of living. We're very lucky to have that. And, I always say that we've been lucky in Alberta that we've had pretty good government. It doesn't matter whether it's NDP or social credit or what have you. They've, some of them have a bit crazier policies than others, but all of them reinvest in the population, and there's none of this sort of broad problems with, people taking handouts and stuff. So we've got good governments, and we've had good healthcare because of that. So we've been very lucky. And the fact that we use so much immunoglobulin, both IVG and SCIG, is, I think, a testament to that. I think we are much more aggressive at diagnosing immunodeficiency disorders. We're more aggressive at treating them, and we're more aggressive at using all these antibodies in immunosuppressive ways. And as soon as a recombinant version comes along, I think you'll see people shift wholesale. And as Kyla was saying, although Canada is, one of the biggest users per capita of antibodies on the planet, it's actually worse than Alberta. So we're the top user, probably.
I think that's up to your clinic, which is wonderful. Thanks, Dr. Ritchie.
And I will say as well, I know you're wrapping up, but I think that patient organizations such as CIPO have a tremendous role to play. And as a clinician, as a researcher, as an educator, I see the impact of your work in our field. And I just want to thank everyone at CIPO for all the incredible advocacy that you do. I think it's such a nice partnership.
Thank you so much, Kyla. That means a lot. We do work really hard, especially when it comes to the plasma sufficiency. I do want to just have one more question for each of you, and it's one that I'm going to ask you both. So for our patient population who have been in isolation or who have had COVID, what can you both recommend just to help them to kind of combat the isolation and or feel better during COVID? What resources or what can you say to them to kind of help them get through this time?
Yeah, I'll start maybe, Bruce, I'll keep it short. I think today we've talked about a number of different layers of protection, and that's such a constant message we've heard through public health. I imagine the application of those multiple layers as sort of a Swiss cheese model, right? There's no one hole that goes all the way across a piece of Swiss cheese, right? If it's a big slice, a pie slice, but that's because you have all these other layers that are sort of intersecting and sort of builds a bit of a wall. So I think that, hand washing is important, masks are important, social distancing is important, have a risk assessment for, social interactions. I think family and school are important, and take advantage of our spring and summer weather that should be coming soon.
Thank you, Kyla, so much. Bruce, same question.
Well, I'd echo that. I'd say life is uncertain. In fact, one of my colleagues in Calgary developed a family shield that involved crossed ice cream scoops. And the motto was, life is uncertain, eat dessert first. And I think that's a good philosophy. I think you have to do the best you can, get all the vaccines you can, use whatever protective things you can. But at the end of the day, there's a lot of stuff that you can't avoid. And I think with the Omicron and the BA2 variant, they're so unbelievably infectious that a lot of our people are going to be affected. And by far, most of them are going to be fine, and they're going to get through it, and they'll be fine. A few of them will end up with severe disease, but we have very good healthcare in Canada, and it's going to look after them. I've had this philosophy in life, which is prepare for the worst, but always hope for the best. Count on Murphy's Law that what can go wrong will go wrong. So be prepared for that. I've always said to people, if you have a will and life insurance, you won't need it. It's only when you don't have those things that you really need it. So I guess my advice is, do your best, but at the end of the day, just try not to panic. In my own family, one of the best things that happened in the last month is when my children and grandchildren all got COVID. My youngest son and his family were tested positive the night before they were supposed to go to Cuba for a vacation. So they ruined all that. But by the same token, although they were sick for a number of days, they're all feeling much more confident now, having gotten through it. And I think the vaccines probably helped them to have a less severe case. So all you can do is do your best and know that we're out there to help you. People like Kyla and myself, we get paid pretty well to help you guys, and we really want to do a good job of that. Even when you phone us up, we're like lawyers. We count by the 15 minutes. You don't get a bill, but the government does.
I would say ask any immunologist, ask your care providers. They will tell you that we have the best job in the world because we have such committed patients, and we really do love what we do, and we are here to serve. So reach out.
Yeah.
Thank you both so much. Sorry, Bruce. I don't want to cut you off.
Don't hesitate to ask for help. We're always here.
You guys are, and thank you both so much. Obviously our co-chair of our Medical Science Advisory Committee, Dr. Bruce Ritchie, and our medical director, Dr. Kyla Hildebrand. Thank you both for taking the time today to answer our questions. If you have any further questions, thank you all for joining us today. If you have any other questions, you can email us at info@cipo.ca. This has been recorded and it will be posted on our YouTube channel, hopefully by tomorrow. Thank you again. for joining us. You can email us more questions, and you can always follow up with Dr. Ritchie or Dr. Hildebrand. Thank you.
Bye-bye.
Thanks, everyone. Bye.
Bye.